Welcome to Variations 4. This is the integumentary unit, burns specifically. In this unit, we're going to cover questions number 10 to 14. So number 10, explain the differences in level of sensation and difference of appearance between the full thickness and partial thickness burn. Well, first let's look at figure 26.3 in the PowerPoint just to get a visual on this. And here we have 26.3 up here. So it used to be called first degree, second degree, third degree burns, but now we've changed the language. You know, like the average burn you get in the kitchen from touching a pan or a hot stove is what they call a superficial partial thickness burn. As you get deeper down here, they call it the deep partial thickness, and as you get down to bone and muscle showing up here, they get what's called the full thickness burn. So these are the classifications. And then if we look back here as to how each one is described, we can look at our answer key and kind of make sense of those classifications now. So for a partial thickness, which honestly I think is a burn we're all pretty familiar with, we get it, our kids get it, you know, it's just part of life. Nerves and blood vessels surrounding the wound are still intact, and that's why there's still blood flow there. It can get quite reddened from the inflammatory process. That's a good sign of circulation to the area. And you certainly have sensation because we can feel it in terms of pain. And you get the exudate sometimes, you know, even from a sunburn, you get that exudate. Okay, so there's your partial thickness. Moving down, and now we're going into destroying nerve endings, and we could even be causing some blood stasis, thrombi formation. So the area becomes more dry and waxy, white or necrotic. So, you know, your sensation here is going to be decreased or absent, and healing is slow. Skin grafts are typically necessary, and infection, you know, complications of infection and whatnot are the risks are quite high. So explain number 11, explain the danger of circumferential burns. Well, first of all, what is a circumferential burn? That means to be around something. You could have a circumferential burn around your finger. You could have it around your torso. And let's see what we have in this PowerPoint. I believe there's a picture here. Well, here's a circumferential burn on someone's leg. So just using this picture to answer the question, first of all, you can see that, compare the flesh, not burned. You can see this is waxy. You can see it's leathery. It's not going to do its job that the integument's supposed to do. There's no flexibility in that. It's tightened and it's compressing. It's like having a cast on now. Now it's like having a cast on that's too tight. It's compressing vessels, blood vessels, so circulation's impaired to the extremity. It's compressing nerves. So there could be pain or there could be absence of sensation, and again, a risk for you know, having to amputate the limb. So what they do is they do what's called an escharotomy, where they cut through the eschar, which is the kind of burnt and deadened tissue and fibrotic tissue, like they've done here, like splitting a cast, basically, to loosen everything up to try and restore circulation and blood flow. The risk, if you don't get it, is the loss of circulation and blood flow could result in the need for amputation and loss of use of the limb. One or both of those things. So if we just go back to our questions now, we'll see if we've more or less covered everything we wanted to say there. Okay, yes, we have. Okay, question number 12. So, I mean, we'll look at the concept maps for this one. I mean, basically, why would people with these conditions have a more complicated time associated with burn injuries? And it's really the same reason why people with these conditions would have a tougher time with many other health issues too. Obviously, the more comorbidities you have, the more complicated healing is and delayed. But let's look at this specifically in terms of burn injuries. So just looking at the top here of your map, page number 5, and just seeing how these comorbidities complicate healing. And I think, we can really talk about this in general with many health issues, but I mean, this unit's on burns, so let's talk in that context. So when you have your burn injury, you have your fluid and light disruptions, as we talked about. We've already talked about that in this unit. So the workload needed from, if you've got renal failure, that's going to complicate things even more. And we've even talked about how renal failure can affect, for example, acidosis, etc. So it could be caused by the burn, or you might be starting out with renal failure in the first place if you have like a chronic dialysis patient, for example. The fluids and lights shifts, changes also, and light, all those changes are going to increase demand on the cardiovascular system. And so even getting the boluses can put the heart under workload. So if you have a heart that is weak, CHF or something to begin with, this can really complicate things here. You can have, we talked about how you can have smoke inhalation injuries. You could also have damage to the intercostal muscles from fibrosis, from the inflammation. There's a couple of reasons why you might have respiratory issues from the burn alone, whether it's something to do with circumferential burn around the torso, inhalation of smoke, maybe there's some edema from inflammation, irritation from the smoke. It goes on and on and on. If you have a respiratory illness underlying all this, that's going to complicate things even more. Okay, and diabetes can affect circulation, as you know, and that kind of ties into all this. And the peripheral vascular disease, well, that slows down healing to peripheries in the first place. So now if you combine that with things like lower limb circumferential burn, just one example of many, that could increase the need for amputation, for example. So question 13 is asking us what the key features are of the following phases of burn management. That is 1, the emergent phase, 2, the acute phase, and 3, the rehab phase. Well, first, let's just say that the overlap between these 3 phases is pretty big. There's a lot of overlap, especially between acute and rehab. But we're just talking about them individually for academic purposes. In real life, you get a lot of overlap here. So generally speaking, the goals of the emergent phase are fluid resuscitation and mobilization of interstitial fluid. In other words, getting that fluid out of the tissues back into the circulation, getting perfusion back to key organs. It's kind of like it's the life over limb stage. Let's get this patient, keep this patient alive. Let's make sure their brain and other key organs are getting perfused here. And if we can decrease the edema along the way, we'll do that too. It may include the use of vasopressors, corticosteroids to reverse the inflammatory response. But of the two, vasopressors, which cause vasoconstriction, is the preferred route because corticosteroids predispose the patient to greater immune deficiencies, and they're already at risk for infection from the burn itself with all that skin loss. They're exposed. There's no covering. So corticosteroids could be used, but it's not the best choice because it can lower their immune response, and they need a strong immune system to fight off the possibility of infection. They'll need IV boluses and diuretics. So that's kind of an overview of the emergent phase. We'll just look at the bottom of map 5 here to see what we can say about the other 2 phases. So the emergent phase we talked about, that's mobilization of fluid and diuresis. Get the perfusion going to keep the patient alive. The acute phase is, now they go up to the acute care ward, the acute burn unit, and it's really about, preventing infection and promoting healing of the wound, whether it's a skin graft or not. is is the skin graft going to attach itself and stay nicely, or is it going to become infected and become rejected by the body? So the acute phase is really trying to manage all that, prevent infection. The rehab phase, of course, is getting the patient back to the maximum degree of functioning they can with their new condition. Maybe it's the same as before, maybe it's less. You can imagine that that goes on in the community as well. And you can also imagine that that begins even before the acute phase is over. We see it all the time in acute medicine and surgery. People start rehab long before they're going to be discharged from acute care. So these two phases especially overlap. And you can see even here it's showing some overlap. Okay, and then finally, question number 14 is asking us to go through a head-to-toe diagram and just discuss the responsibilities and understand the treatment approaches for each item on the head-to-toe diagram for the emergent phase of burn injuries. So let's take a look at that diagram on map number 8. So I'll just kind of hover through it, and if there's something that needs to be explained, a lot of it we've already talked about above, or it's already intuitive. Like a lot of these things up here that I'm hovering around with the mouse should be pretty intuitive, that these are issues that need to be addressed. Decreased vascular flow to ears predisposes, that's a major area for potential pressure injuries. So you want to watch that there's no pressure against the ears. I don't know what kind, if there's a special pillow, or you just need to be careful of that. So a lot of this picture is, we've covered it already, or it's pretty intuitive. So I'm going to leave that question at that for you to look at yourself.